Hello, and thank you for joining us for a special plenary session with CDC Director Dr. Rochelle Walensky. Dr. Walensky is the 19th Director of the CDC and the 9th Administrator of the Agency for Toxic Substances and Disease Registry. She's an influential scholar whose pioneering research has helped advance the national and global response to HIV/AIDS. Dr. Walensky is also a well-respected expert on the importance of testing and treatment for deadly viruses. Before she was named director of the CDC, Dr. Walensky served as the chief of the Division of Infectious Diseases at Massachusetts General Hospital from 2017 to 2020. And she was professor of medicine at Harvard Medical School from 2012 to 2020. It was in these roles where she worked alongside many of our members at Mass General and Harvard. Her pioneering research has helped advance the national and global response to HIV/AIDS, and she's served on the front line of the COVID pandemic and conducted research on vaccine delivery, strategies to reach underserved communities. Dr. Walensky is recognized internationally for her work to improve HIV screening and care in South Africa, and is nationally recognized for informing clinical trial design to deliver evidence to motivate health policy in a variety of settings. Before I turn it over to her, on behalf of all of our U.S. and international members, and myself as a former EIS officer, we are grateful for your efforts to return CDC to its rightful place as a leader in global health and a premier science-based agency globally. Thank you for taking time during the pandemic to address our attendees. Dr. Walensky.
Thank you, Dr. Jacobson, for that kind introduction. It is a pleasure to be with you all today, even if only virtually, and I look forward to a time when we can meet in person. The last 20 months of the COVID-19 pandemic has taught us so much. We've learned a lot about ourselves, about our scientific capabilities, about the gaps we need to address to truly tackle and prepare for pandemic threats in the future, and overcome health inequalities that exist in our country and throughout the world. I know that many ASTMH members have likely been deeply impacted by COVID-19, either personally or professionally. This crisis highlights the power of scientific collaboration. It will only be by working together that we can confront this pandemic and the other pressing public health challenges of our time. I'm sure many of you remember where you were when you realized that the COVID-19 pandemic was beginning to take hold. For me, I was serving as chief of the Division of Infectious Diseases at Massachusetts General Hospital. I will never forget the moment that my pager went off, March 6th, a Friday morning, alerting me to the first case, indeed cases, of COVID-19 in our hospital, and how everything changed after that. Our hospital was quickly overtaken by the pandemic. As we worked frantically, I was constantly thinking through how we could reach underserved communities, incorporate evidence-based guidance into our treatment, and how we would eventually deliver vaccines. At the core of each of these decisions was how we would do our work equitably. When I came to CDC in January, almost a year after the start of the pandemic, I immediately made it clear that the same principle, health equity, must be at the core of everything we do, whether it be domestically or in our global work. Our work on COVID cannot cause us to lose sight of the precious progress that has been made and needs to be made on our other infectious disease control and elimination targets, such as malaria, dengue, Chagas, lymphatic filariasis, and guinea worm disease, many of which impact the most vulnerable countries and communities around the world. The recent cases of melioidosis in the United States provide us with one more illustration that diseases, even very rare tropical diseases, know no borders. Between March and July 2021, we confirmed 4 linked cases, including 2 tragic deaths, of melioidosis in patients from Georgia, Kansas, Minnesota, and Texas. As you know, most cases of melioidosis in the United States are in people who travel to areas where the disease is more common. But these patients had no recent travel history or international travel and had no recent contact with one another. Dr. Alex Hoffmaster led a team of epidemiologists and laboratory scientists looking for the cause. They investigated items such as personal care products, lotions, soaps, food, vitamins, and cleaning products. All of them resulted in dead ends until the team went back to the home of the last patient for one more look. There, they collected a specimen from an aromatherapy spray, a product produced in India, and from that specimen, they got positive PCR results for Burkholderia pseudomallei. Further testing identified the same bacteria in all 4 patients. The hunt was over, although the investigation continues to see if there are related products that pose a risk. This is what our scientists are called upon to do, the painstaking, time-consuming detective work that it takes to solve these kinds of mysteries. So rewarding when we solve the mystery by unexpectedly finding a connection to a disease more commonly found halfway around the world. Whether it is COVID-19 or Burkholderia pseudomallei in an aromatherapy spray, CDC's global portfolio is critically linked to our domestic public health agenda. More than 75 years ago, CDC was established as the Agency for Malaria Control in War Areas, created to keep the southeastern states malaria-free during World War II. We still see approximately 2,000 travel-related malaria cases per year in the United States. And as international travel and commerce continue on their trajectories towards pre-pandemic levels, we must remain vigilant against infectious health threats, both globally and here at home. During the pandemic, CDC, as co-implementer of the United States President's Malaria Initiative, or PMI, was able to support malaria control in key countries despite the challenges. For example, delivering bed nets and medicine door to door meant workers and families could avoid crowded collection points. As our understanding about the risk of transmission of SARS-CoV-2 through asymptomatic individuals has emerged, we were able to leverage our existing malaria surveillance systems, which provide population estimates of asymptomatic infection, to better understand SARS-CoV-2 transmission in the population. And we are very proud that CDC's malaria researchers worked alongside our partners to develop and evaluate the groundbreaking new RTS malaria vaccine approved last month by WHO for broader use. Of course, we know that mosquitoes cause more death and disease than any other animal on the planet, and CDC is fighting mosquito-borne diseases on many fronts. We have committed, thanks to funding from the American Rescue Plan, to work with other countries and international partners on the feasibility of implementing and assessing the impact of several novel vector non-insecticide sterile insect techniques, such as mosquitoes with Wolbachia and genetically modified mosquitoes for mosquito control. We're partnering with WHO and other organizations in the Eliminating Yellow Fever Epidemics, or EYE, strategy. We continue to make and distribute critical reagents for the timely detection of yellow fever and have assisted in training laboratory staff in the Americas and Africa, where yellow fever is endemic, to ensure reliability of diagnostics. And we are working with WHO to determine yellow fever risk to be able to optimize vaccination activities. The pandemic did not stop our work on dengue. In June 2021, CDC's ACIP recommended Dengvaxia for use in children who have laboratory-confirmed previous dengue virus infection and are living in areas under our jurisdiction where dengue is endemic. The United States territories of American Samoa, Puerto Rico, and the U.S. Virgin Islands, and freely associated states, including the Federated States of Micronesia, the Republic of Marshall Islands, and the Republic of Palau. CDC evaluated dengue laboratory tests to develop guidelines for pre-vaccination screening and will provide diagnostic reference panels. We also developed communication and training materials to support the vaccine rollout and continue to support dengue surveillance and outbreak response nationally and internationally. We're leveraging our surveillance systems and tropical disease programs to expand our abilities to make timely diagnoses and provide life-saving treatment. For example, in Belize, where we have implemented a regional acute febrile illnesses surveillance network, we were able to detect Chagas disease in this endemic country and also help local health authorities to determine and identify more than 30 undiagnosed cases of COVID-19. The COVID pandemic threatens to reverse some of the progress made globally against neglected tropical diseases and put millions of people in impoverished areas back at risk of infection. We are working hard to make sure that we continue to move forward. Last year, CDC microbiologists provided virtual training for Tanzania public health workers on how to properly administer rapid diagnostic tests for onchocerciasis. Training in laboratory-based skills is particularly challenging since it requires review of the techniques used by each individual laboratorian. The team incorporated movable cameras and real-time communication applications to help get the information across while still maintaining physical distancing and limiting the risk of COVID transmission. This training was part of a larger effort to accurately map untreated areas where onchocerciasis transmission may be occurring. American Samoa is the last remaining American territory with known ongoing transmission of lymphatic filariasis. CDC is providing technical expertise to local partners in American Samoa to help drive elimination of lymphatic filariasis by 2025. We're providing technical assistance for planning and implementation of program activities, including mass drug administrations, impact assessments, and coverage surveys. In 2020, we conducted virtual training so the territory's public health staff could carry out the planned impact assessment and conduct mass drug administration, which kicked off this October. The COVID-19 pandemic did not stop outbreaks of Ebola. The Democratic Republic of Congo is now experiencing its 6th outbreak in the last 5 years. As of November 10th, there have been at least 8 confirmed cases and 6 deaths in the current outbreak. Genetic sequencing indicates this outbreak is linked to the 2018-2020 outbreak, raising questions about whether these new cases are the result of sexual transmission or relapse of Ebola in a survivor. The implications of viral persistence in survivors requires critical attention, considering the thousands who have survived Ebola outbreaks during the past decade. While the world has been focused on the COVID-19 pandemic, CDC collaborated with other agencies across the government, our international partners and ministries of health in Guinea and the Democratic Republic of the Congo to stop concurrent Ebola outbreaks in Zérakore Prefecture of Guinea and Eastern DRC. These are the same regions that historically saw the start of the 2 largest outbreaks of Ebola. In the 2014-16 outbreak in West Africa, there were over 28,600 reported cases, with spread across multiple countries. In the DRC outbreak in 2018-2020, there were over 3,400 cases. Through close cooperation, we were able to support surveillance, laboratory capacity, border travel and screening, infection prevention and control, and community engagements, and the outbreaks this year totaled only 35 cases without any international spread. We are committed to do the hard work to ensure Ebola is contained, even as we continue the fight against COVID-19. Important to CDC's COVID-19 response are our global health security investments and decades of global cooperation and support across our global public health portfolio, including the CDC Disease Detection Specialists and our Global Disease Detection Operations Center, who monitor public health threats 24/7 across the globe. Surveillance systems and laboratories that were developed to advance malaria, HIV, and TB research and program activities were adapted early on in the pandemic to include SARS-CoV-2. For example, during the early stages of the response, CDC-supported laboratories in Kenya were conducting the vast majority of the SARS-CoV-2 PCR testing in the country. An exciting development, made even more urgent by the pandemic, is CDC's work in data modernization. We scaled up to handle an unprecedented volume of data, 1 million lab records per day, 415 million unique immunization records, more than 800,000 genomes sequenced. These are numbers we have not seen in the history of public health and which we are now able to handle. This modernization is critical to the new Center for Forecasting and Outbreak Analytics. The center will leverage interdisciplinary data and expertise to forecast and track hotspots for COVID-19 and other emerging biological threats. The work of this new center will also support CDC and our other public health partners, like members of ASTMH, with increased capacity to translate and communicate forecasts and analysis in near real time and to share timely information. We will be able to do more research, find better tools, and use data more efficiently, and then translate and communicate what we learn more effectively. In addition to supporting decision makers domestically, the Center will partner globally with the new WHO Hub for Pandemic and Epidemic Intelligence in Berlin, as well as other collaborative initiatives to improve public health response through better data and analytics. These investments in data modernization, along with investments in preparation for future health threats, both global and domestic, strengthening our laboratory infrastructure, and building back our public health workforce are what it will take to overcome the challenges faced by global health now and in the future. And lastly, many of the tropical diseases I have mentioned and that you focus on are further impacted by the threat of climate change. CDC's Climate and Health Program is celebrating its 10th year as the national leader in empowering communities to protect human health from a changing climate. In fact, this program is the only U.S. government investment dedicated to preparing our nation to anticipate and adapt to the health effects linked to climate change. We are seeing that higher temperatures, changes in rain patterns, and disrupted ecosystems lead to changing patterns in the spread of vector-borne diseases. Disruption in environmental conditions and habitats are providing new opportunities for diseases to pass to animals and, in some cases, to us. Likewise, extreme weather events can cause food insecurity, waterborne illnesses, cardiovascular disease, injury, and even death. Like all health crises, everyone is not equally at risk. We've seen that after extreme weather events, socioeconomically disadvantaged and marginalized populations sustain disproportionate harm and loss, making this an issue of health equity. We will not be successful without the sustained dedication and expertise of partners like you. Having known and interacted with many of you over many years, we at CDC remain optimistic for our success against the challenges ahead. Thank you for inviting me to be here. I turn the podium back over to Dr. Jacobson.